And I'm going to talk about phosphorus and renal health. And what I'm going to try and do is to give a review of how the body regulates phosphate, and then move on to reviewing some studies. Some are quite old and some are quite new, about how phosphate and the diet can actually be damaging to the kidneys. Is that actually happening? And then to review at the end the evidence for restricting phosphate in the face of chronic kidney disease and the benefits that accrue from that. So that's the plan. So phosphate homeostasis. Homeostasis is all about balance. If intake equals excretion and the animal isn't growing and it's not lactating, then everything stays in balance. And until 2000, we didn't really understand what the specific regulators were for phosphate. We knew that PTH regulated phosphate and increased phosphate excretion, but the thing that stimulated PTH secretion, we thought, was ionized calcium. And so how did that really work? So in the 2000s, there were a number of compounds, number of hormones that were suggested, and they were given the name phosphatonins. And one of those, FGF23, we've mentioned already. It is one of the phosphatonins that we know most about, and there are others, and they may have other effects. So regulation of phosphate homeostasis in the 1990s was explained through the action of PTH and calcitriol, but now we have this other player. And this other player is key because it's able to regulate intestinal phosphate uptake and able to cause the excretion of phosphate without mobilizing calcium and phosphate from bone. So if we're thinking about homeostasis of phosphate, there are really three key target tissues: intestine, bone, and the kidney. So intestine is where the phosphate comes in. Bone is where phosphate can be stored but also retrieved. And the kidney is what really regulates the excretion. And the hormones that are important, and they do all interact, is FGF23 and alpha-klotho. Alpha-klotho acts as a co-receptor for FGF23. So it binds to the FGF23 receptor, that's the receptor that is mediating most of the actions that we're going to talk about today. And it's needed for that purpose. And it's produced by the kidney, which is important. Parathyroid hormone and calcitriol you're all familiar with, but how they interface with FGF23 is important. Now, we tend to measure one of these factors and ignore all the rest, whereas really what you should be doing in this system is measuring everything and trying to integrate it into one model to study the whole system and how it works. And it's a very simplistic view to assume that calcium homeostasis is separate from phosphate homeostasis. I think those things go on together, and there's more to it than I'm going to say in this talk. So I've put up this diagram, which was a diagram produced by Natalie Finch in her PhD thesis, and she was the first in our group to start looking at FGF23. And I'll put FGF23 in this corner and just talk about its actions. So it has an action to reduce phosphate. It also has an inhibitory action on PTH. I'm sorry, some of the letters seem to have disappeared in this diagram. I'm not quite sure where, but hopefully you'll work it all out. And it has an inhibitory action on 1,25-dihydroxycholecalciferol, which is much easier to say as calcitriol. Calcitriol is a thing that influences the gut and the uptake of calcium and phosphate from the gut. So you can see that FGF23 has inhibitory effects on intestinal uptake of phosphate and inhibits PTH secretion, which is the thing that mobilizes phosphate from bone. So it's cutting off those two supplies, if you like, of phosphate, and it's increasing the excretion of phosphate through the kidney, provided the kidney is working correctly. And that's one of the things that limits the kidney's role in and its ability to adapt to loss of functioning nephrons when it comes to phosphate, because there are no secretory mechanisms for phosphate. It's easy for the kidney to adapt to excrete more potassium per nephron because it can secrete more potassium in the distal tubule. All the kidney can do with phosphate is regulate how much is reabsorbed in the proximal tubule, and actually it does need to reabsorb some phosphate in order to take up enough sodium for the animal. It's one of the transport processes that returns sodium to the body. So the thing that we don't really understand is what happens in this pathway. We know that FGF23 is produced by bone, but we don't know what is the stimulus for its production. Is it chronic overload of phosphate? It doesn't appear to be acute changes in serum phosphate, as we'll talk about in a minute. So that's my simplified view of the world. There is a lot more to it than that, and there are effects of alpha-klotho directly. There are effects of FGF23 on calcium, so this whole system integrates together. So the next thing I want to talk about is the different types of phosphate in the diet. Phosphate in pet food comes from, as Vincent mentioned, the raw organic materials, so bone meal in particular, and meat and muscle are rich sources of protein and phosphorus. And that's bound up with the protein and with the calcium, and it's slowly released and slowly digested. But there are reasons for putting inorganic phosphate into diets, and there are a number of these. They're added to enhance the texture, to make the food more palatable. They chelate calcium and prevent tartar on the teeth, for example, and they're used to make the diet balanced. So you need to add that inorganic phosphate to balance the diet up, to get the right calcium to phosphorus ratio. But they are readily available for absorption from the gastrointestinal tract, and they enter the blood more rapidly than the organic sources of phosphate, and so that's important. In human nutrition, many of the processed foods have inorganic phosphate added as a preservative. And so the sort of cured hams, for example, will have a high level of inorganic phosphate. And they're obviously nice and tasty. So what epidemiological data are available that suggests that phosphate intake is, high phosphate intake is harmful? Well, in human medicine, the recommended daily allowance is 700 milligrams, and most people in the Western world exceed that recommended daily allowance. There is a link between excess dietary phosphate and cardiovascular disease in particular, and phosphate is involved in mineralization of the vasculature. So that's probably where that link comes. It's much harder to draw that link between phosphate intake and kidney disease, because it's really hard to know when a person started to have kidney disease. And if you look at a whole population, and obviously the advantage for human medicine is that they can do their epidemiological studies with thousands of people involved and follow them over much longer periods of time. But the study that I'm showing here shows that the upper quartile of this population of people had phosphate above 3.8 milligrams per deciliter. Remember that the target levels for a patient, a kidney disease patient, stage 2, would be 4.5 milligrams per deciliter. So here we are in this range, and these patients were at 133% higher risk, so a 33% higher increase in risk of needing to go on dialysis in the future, which is a useful endpoint for human medicine to use. That was regardless of their EGFR to begin with, when they were first sampled. And if you take the subset of these people that had an EGFR above 60, which is considered to be normal, then those patients were still at increased risk, or those subjects were still at increased risk. So that suggests that there is a link between kidney damage and high phosphate. Another piece of evidence shows that acute effects of high phosphate intake are damaging or detrimental to cardiovascular health, endothelial cell function. And this study I've chosen to show has relatively few volunteers, but I think is quite marked in the effects that it's showing. What's being measured here is what's called flow-mediated vasodilation, and that is an indication of the health of the endothelium. And endothelial cell health is really important in people, and it's an early indicator that you're developing atherosclerosis in effect. So the flow-mediated vasodilation, the higher it is, the better your endothelium is. What this study did was it looked at two levels of phosphate intake, 400 milligrams of phosphate ingested as one meal, and then 2 hours later the flow-mediated vasodilation was measured, or 3 times that level. And what you can see is that the open circles are the postprandial measurements. And when you have a high intake of phosphate, they're clustered down here, and postprandially, the flow-mediated vasodilation is reduced. So the endothelium is not working as well after a high phosphate meal. Now what we see as a result of high phosphate intake over a period of 4 weeks or so is proteinuria, albumin appearing in the urine, which could well be due to a reduction in endothelial cell function. And that might be an initial, if you like, damaging effect on the kidney, perhaps. Lots of ifs and buts. So let's look at the animal studies. We've known for a long time that if you feed a lot of inorganic phosphate, then it gets deposited in the kidneys are mineralized, the bones are demineralized, there's a lot more phosphate going out in the urine, less calcium going out in the urine. And that was true in rodents, is true in dogs, and is true in cats. And you see this demineralization of bone occurring, which suggests that you're activating parathyroid hormone. And actually that the phosphate, the high levels of phosphate that are going through the tubules are ending up causing tubular mineralization. A study that was published last year in the Journal of Feline Medicine and Surgery looked at 3 times the maintenance level of phosphate for 29 days. And if you look at the phosphate content of the diet, you'll see in grams per kilogram dry matter here. I wish nutritionists would just standardize the way in which they express their dietary contents, but perhaps it's a way of just, they can convert easily themselves and keep the profession to those people in the know. This was a 29-day study, so the cats were fed the high diet for 29 days, and then they were crossed over, or they started on the lower diet, and then they were crossed over. But one of the problems with this study is that the crossover period was a long period of time between the 2 dietary periods. This was not a study that was planned in a way. It was more of a convenience study, I surmise from reading the paper, and so that's not really the ideal study to have. What they found was when the cats were eating the high phosphorus diet, they had albuminuria. 9 out of the 13 cats had albuminuria, and they found glucoseuria also. That's not something that anybody else has reported in response to high feeding of phosphate, and it's a surprising result which I'm not able to explain. Glomerular filtration rate was reduced during the period of high phosphate feeding, reduced quite significantly from 3 to 2.4 mils per kilogram per minute, and that was measured by a creatinine clearance method. So what wasn't seen in this study was a reduction in the plasma concentration of phosphate during the fasting period, so preprandially, which is something that's reported in the other studies that I've mentioned and in the ones that I'm going to go through now in some detail. So this prompted a group at Waltham to look at this in more detail. And a paper has just come out in the British Journal of Nutrition reporting 2 studies, and I'm going to go through those 2 studies. The first study, called FOS1, had a baseline period for 20 weeks, and the cats were fed a relatively low phosphate-containing diet, actually as low as some of the renal diets, 1.2 grams per 1,000 kcals of phosphate in this study. That was the baseline diet. Then 48 cats were block randomized based on their age and their body weight to receive either 4.8 grams of phosphate per 1,000 kcals or 1.2 grams, the same as the baseline. But the difference was made up by adding inorganic phosphate. And so that was 3.6 grams per 1,000 kcals of inorganic phosphate. And the calcium to phosphorus ratio between these 2 diets was markedly different. So it was 0.58 in the high phosphorus containing diet. And the renal health markers were followed, and the bone and mineral disturbance markers were followed. It was intended that this study would last for 36 weeks, but after 4 weeks, the cats didn't look too good. There was a significant reduction in GFR. Interestingly, there was a significant reduction in both groups, but the group that were receiving the control diet actually had higher GFR after 4 weeks than the group that was receiving the test diet being in red, and that will be the same, and the control diet in blue, and that will be the same for all of the subsequent slides that I'm going to show. As you might expect, GFR falls, plasma creatinine concentration goes up, plasma urea concentration goes up, and you can see there is a fair spread of the data, but the average data are statistically significantly different between the 2 groups. That was the same for SDMA as well. So these changes in GFR are reflected in those plasma markers. FGF23 increased by about 4-fold. PTH increased by about 2-fold in these cats. So we're activating those systems, but we're activating them in a maladaptive way to a certain extent, because what FGF23 ought to do is to control PTH. And these are all fasting samples. Renal imaging showed that 22 test cats had changes that's 22 out of 24, in the echogenicity, indicative of altered renal morphology. So there were subtle changes in 3, there was a narrow sort of rim sign, a broad rim sign in another 14 cats, and then broad parenchymal speckling, and there was some nephroliths found. So there were structural changes in these kidneys as a result of 1 month of feeding this high phosphorus diet, and the urine albumin to creatinine ratio was markedly different. Now, interestingly, the urine albumin to creatinine ratio that we see in aged normal cats runs up to around about 70 milligrams per gram of creatinine. So these weren't outside of what we would consider to be an abnormal range, but if you take their starting point, they certainly were excreting more albumin at the end of the 4-week period, whereas the cats that were fed the control diet, there was no change in albumin excretion. Within the same paper, there was a second study that was done with lower levels of phosphate supplemented, and this was FOS2. This followed on from FOS1, and in this particular study, same design, but the cats were supplemented with inorganic phosphate to the tune of 2.3 grams on top of the base diet, which again was low in phosphorus to begin with, at 1.3 grams per 1,000 kcals. So the test diet in this instance is shown in yellow in all of the slides, and the control diet is shown in blue. The calcium to phosphorus ratio in these 2 diets was similar. Obviously it was lower in the cats that had the phosphate supplementation, but it wasn't as marked in terms of the difference compared to the FOS1 study. What the first slide shows is that the GFR was relatively stable over the period of time, but what that doesn't take into account is that there were 3 cats that dropped out of the the test group towards the end of the period of feeding. And this period is a 6 months period, so 28 weeks in this instance. What we see with the fasting inorganic phosphate concentration is that it's lower in the group that are fed the higher level of phosphate. Now that seems counterintuitive, and what that suggests is that the homeostatic mechanisms are overcompensating, and by the time the cats are fasted and are waiting for their next meal, their plasma phosphate is lower. And I'll show you the data from the acute feeding. What we don't know is how long does it take to adapt, and is there an adaptive process in this period. And you can see that statistically significant differences between the two groups were seen at the 3 later time points here. FGF23 actually was elevated significantly by 2 weeks and remained elevated, although not quite statistically significantly different at each time point, but at most of the time points, at 2/3 of the time points, it was significantly different. And there were some differences in PTH, but only towards the end of the study. So there was more variation in PTH than there was in FGF23 in terms of its statistical significance. What really showed up very clearly was that these cats started to lose albumin through their kidneys at the first time point this was measured, which was at 4 weeks. And if you looked at just the plain concentration of albumin in the urine, there was no overlap between the two groups. So that seems to me to be an early marker that there's something going on here that is stressful to these cats' kidneys in this group. When we looked at renal imaging, then 15 of the 25 cats in the test group had developed nephrolith. Now there was quite a high proportion of cats in the control group that also developed nephrolith. And so that's really a confounding factor in terms of interpreting the data from this study about the background level of nephrolith formation in these cats. None of them had nephrolith to begin with. They were all imaged and screened in order to be enrolled into this study. And there was evidence of structural changes in the kidneys on ultrasound in 9 of the 25 test cats. I should say that all of the cats from FOS1, I forgot to mention this, were taken off the diet at 4 weeks and have been followed longitudinally over time. And 17 of those cats are still alive today and are still being followed over time and are not markedly azotemic and don't have progressive kidney disease. So although there's been some structural damage to those cats' kidneys, they have, once they've been fed a balanced diet with lower amounts of phosphate in there, actually got back into balance and are functioning reasonably well. So the conclusion to these studies, the level of phosphates that is included in standard maintenance diets for cats should be reevaluated. Diets containing highly available inorganic phosphate seem to lead to a reduction in GFR, reduced fasting plasma phosphate, and high excretion of phosphate and some albuminuria. I've mentioned how much phosphorus was added to these two diets and what the calcium to phosphorus ratio is. That's important, but other components in the diet will influence the availability of phosphorus. The control diets in these studies were both actually quite low in phosphorus, so we're comparing to a cat that's adapted to a low phosphorus diet. Does that make a difference? If you took cats that were used to eating a lot more phosphorus, would they be better able to handle that? There are the indicators of renal health that are there in these studies are microalbuminuria and structural damage to the kidneys. And obviously with a high level of phosphorus feeding, there was changes in GFR, which in other studies have been reversible changes in GFR. What the group at Waltham have gone on to do is and published also in the British Journal of Nutrition in a separate paper, is to look at the acute responses to phosphate feeding. And I'm just going to show some of the data. It's a hugely complicated paper. I would never have tried to publish all of this data in one paper if I'd been given the option, and therefore you really need a couple of days to read it very carefully. But what I'm showing here is the effect of feeding, in effect, the FOS1 diet, test diet, over a 6-hour period. It does put up plasma phosphate over a 6-hour period. And in response to that is a reduction in ionized calcium over a 6-hour period and an elevation in parathyroid hormone, but no change in FGF23 in that 6-hour period. Okay? So it appears that that highly available phosphorus is readily absorbed from the intestinal tract, binds with calcium in the serum, and stimulates PTH. Now that might be a very simplistic way of looking at it, and there could be other mechanisms involved. But that test seems to be one that predicts, or Waltham Hope predicts, whether there is too much inorganic phosphate available, if you see that response. Not all sources of phosphate are the same. So what was added to the diet was monosodium dihydrogen phosphate in the 2 feeding studies that I mentioned earlier. And what we saw just then was SDHP added to the diet. But if you add other forms of phosphorus, you may get differences in terms of the availability. And the one that's been studied in addition is STPP, sodium tripolyphosphate. And that seems to have an intermediate effect. It's slightly less available, and it puts up the plasma phosphate, but for a shorter period of time. So this is one of the studies that's mentioned in the paper. What we're looking at here is a diet that is a bit like the that has sodium dihydrogen phosphate at 1.5 grams per 1,000 kcals and organic phosphorus at 2.3. So it has a total that's the same as FOS2, 3.8. And that gives this increase in plasma phosphate over a 6-hour period, and that doesn't come down. Whereas if you feed the same, or actually more, total phosphate, so this would be a 4.8 grams per 1,000 kcal, the same as FOS1, but different because only 0.5 grams per 1,000 kcal is coming from inorganic phosphorus sources, then actually you see no change in plasma phosphate over time, no change in PTH also, but I'm not showing the PTH levels. And then if you go intermediate and you have these 2 diets, then you actually see the same result, but this is with the different form of phosphate, the STPP, which gives you a less of an area under the curve of the plasma phosphate concentration versus time curve. And just to emphasize that, these are the 2 diets where we've got the sodium dihydrogen phosphate, and we're comparing it to diet J, which has the STPP, and you can see that there is a difference in terms of the return to baseline phosphorus is much more rapid with the STPP diet compared to the SDHP diet, which stays up for longer. So just to conclude, readily available sources of soluble phosphate lead to increases in plasma concentration of phosphate postprandially. These changes are associated with more marked reductions in ionized calcium, increases in PTH, and result in phosphate excretion in the urine, as you would expect. That phosphate is coming both from the plasma absorbed from the intestine, but remember, when PTH is secreted, you'll get bone turnover increasing. So you'll get more phosphate added from bone as well that needs to be excreted and put back into bone, actually, over time. So the whole process is turning over more rapidly than it would normally be. The factors that influence this phenomenon will be the dietary calcium to phosphorus ratio. And in the second paper, there are variations in the calcium to phosphorus ratio and showing how that influences the bioavailability of phosphorus. The vitamin D status will obviously have an effect. The amount of sodium in the diet is important because sodium is co-transported with phosphorus, both in the intestine and in the kidney, so it's important in both ways. The meal size and the fiber content, because certainly fiber from plants, cellulose and the like, will bind negatively charged molecules. That's well described in the literature in terms of binding drugs in herbivores that are eating cellulose, and I'm sure that it probably happens in the carnivores eating plant fiber, and could well explain differences between diets. And acidifying diets will also influence how the kidney handles phosphate. Phosphate is an important urinary buffer as well. So what's unknown is whether this phenomenon that we've shown in the acute model of phosphate feeding predicts the long-term feeding effects and the action on the kidney. That's certainly an unknown, and it's something that further studies are ongoing to investigate. So in the last 14 minutes, I've been told I've strictly got to stick to time. So in the face of chronic kidney disease, phosphate overload is detrimental. And Vincent reviewed some of these data, so I will do something similar, but to really talk about the adaptation to reducing the number of functioning nephrons, if you continue to feed the same amount of phosphate, is in the first instance helpful to the kidney to get rid of that phosphate, to get rid of more phosphate per nephron, and therefore to remain in balance. But once it happens that FGF23 response is reduced, FGF23 is able to inhibit PTH, but the Klotho component is produced from the kidneys. Klotho tends to decline as kidney disease gets worse, and that reduces or inhibits the action of FGF23 on its target organs. So FGF23 keeps going up, but it's not able to have the same effects. And actually, it may well have other effects that are detrimental on the vasculature or on the mineralization of tissues. And so is part of this system. So what we tend to see is a phased approach where, first of all, things do get into balance if you're looking at it early enough and you're not seeing an increase in plasma phosphate or in PTH, but then PTH goes up, then plasma phosphate goes up, and things are completely maladaptive. There are therefore extrarenal effects of calcium and phosphate deposits in the arterial walls and in the heart valves. There's microvascular arterial wall thickening, myocardial fibrosis, and in people those are all associated with risk of death. I don't think those have been very well studied in veterinary medicine at all. Our assumption is that we're just looking at the kidneys, but actually these two systems work so closely together. Experimental studies in rats, dogs and cats show that hyperphosphatemia and hyperparathyroidism is associated with progressive damage to the kidneys, and that's loss of function in the dog and the rat, and it's histological evidence in the cat. Whereas restricting phosphate intake can reduce progressive kidney injury and slow down that whole process, and that's something that, again, there are clinical studies as well as experimental studies. So in effect, what we're looking at here is, rather than what was thought about in the 1980s, 1990s, was the trade-off hypothesis. Now we've introduced FGF23, which is, if you like, the brake on the maladaptive system. Once that breaks down in later stage kidney disease, then we lose control and we start to see this bone mineral disturbance, which is related to reduced survival in cats with chronic kidney disease. In the early stage, FGF23 is increasing phosphate excretion and reducing calcitriol, reducing the input of phosphate into the system through the intestine and controlling parathyroid hormone and its effects on bone. And that's all hunky-dory in the early stages, but because the kidney can't secrete phosphate, then the later stages it just becomes maladaptive and PTH starts to kick in. So this is the sort of sequence of events. The very earliest change in human chronic kidney disease patients is a rise in FGF23, and that's particularly the case in those patients that have enough vitamin D in their diets. Interestingly, if they don't have enough vitamin D in their diets, then actually PTH tends to go up first in the large epidemiological studies that have been done. But then as we move through the stages, PTH will start to go up, and it's only when you start to get to stage 2, stage 3 chronic kidney disease that you start to see a rise in plasma phosphate concentration. You start to see a fall in 1,25-dihydroxycholecalciferol as a result of FGF23 from quite an early stage. What makes this maladaptive is once we start to lose clotho, and that's something that is really in its infancy in terms of us studying that in our veterinary patients. And if we were able to measure serum clotho accurately, I think that would make a big difference to our understanding of this picture and to the individualization of this regardless of stage, because these cats will be different. They'll all be individuals. PTH increases when we have loss of clotho and the parathyroid glands then hypertrophy, and then we're into this sort of vicious cycle. This again is taken from a review in human medicine, where the emphasis is on hypertension, cardiovascular remodeling, left ventricular hypertrophy, vascular calcification, and endothelial cell dysfunction, because actually with dialysis, the thing that people die of with kidney failure is cardiovascular disease and the complications thereof. But that probably does contribute to the end stage of our chronic kidney disease patients, both dogs and cats. Vincent talked a little bit about FGF23 at different stages of chronic kidney disease. Here's some more work from Rebecca Geddes' thesis, again showing the proportionate increase in FGF23 at the different stages of chronic kidney disease. And this is a log scale, and so these are hugely different, whereas parathyroid hormone goes up in some patients in stage 2, but it's really the stage 4 before we see the massive elevations in parathyroid hormone concentrations. If we look at a particular stage, then FGF23 actually is excreted via the kidney, so you would expect that reduction in glomerular filtration rate will lead to an increase in FGF23 to a certain extent. However, if you look at stage 2 and those cats that have plasma phosphate within the target range in stage 2 without any treatment, so these are cats that are able to regulate their phosphate within that target range, have significantly lower FGF23 compared to those that are outside the target range, and the same is true in stage 3. So phosphate is playing a role in FGF23 secretion. The same is true in dogs, although there's much less data available in the published literature on FGF23 in dogs. But FGF23 is elevated in stage 2, whereas it is not until stage 3 and stage 4 when we start to see these increases in PTH and increases to a significant extent in plasma phosphate concentration. I showed these data this morning showing that in the pre-azotemic phase of chronic kidney disease, and that's this group 3 here, there's a much higher level of FGF23 compared to normal cats that stay normal and are not therefore pre-azotemic in this definition. Interestingly, the Munich group have taken dietary histories from cats and looked back retrospectively to see whether there was any relationship to the amount of phosphate consumed. And in the 16 cats that they could identify a dietary history that allowed them to calculate the amount of phosphorus that was being consumed, there was that relationship. But they were looking for that, and their study was designed to try and identify it. So I think we need some prospective studies. We need larger numbers of cases in order to understand this. But perhaps FGF23 is predicting, as I suggested this morning, those cats that are overloaded with phosphate already in that pre-azotemic stage, and therefore would benefit from early intervention to reduce phosphate. I've got 5 minutes left. FGF23 is predictive of all-cause mortality in cats with chronic kidney disease, but it's also predictive of those cats that progress, where their definition of progression is a 25% or more increase in plasma creatinine concentration over a 12-month period. And remember, that's about half of our cats that show that change over time, whereas the other half don't. So FGF23 at diagnosis of their chronic kidney disease predicts which cats are going to show an increase in plasma creatinine concentration and actually how long they're going to live. Vincent showed this study from 2000, which was a dietary phosphate restriction study, and showing that phosphate restriction improved survival. These are the data from Linda Ross's study, which was an experimental model, and I would say that the cats that are on the normal phosphate were actually receiving a high phosphate diet, actually, in that study. But you don't need to do statistics to see that those cats had much worse histology in their remnant kidney compared to the cats that were phosphate restricted. What we've done in this study is reanalyze the data on plasma phosphate and its relationship with survival, showing this exponential relationship which seems to turn up at the sort of 1.5 millimoles per litre level, which coincides with the target level for plasma phosphate in human patients that are phosphate restricted. And that's why I argued at IRIS and the various round tables that we had that phosphate should be controlled below 1.5 millimoles per litre. And that seems to be something that holds true. Vincent also reviewed the FINCO study, which gives quite good evidence that restricting phosphate rather than protein influences progression in dogs. And the Minnesota group did an intervention study in dogs, as they have in cats, looking at the endpoint of uremic crises, using Hill's KD diet and showing a similar effect to the one that we showed in the study that we published in 2000 in cats. So it seems to go across species. If you can control phosphate, you can restrict phosphate, then you seem to protect against progression of chronic kidney disease. Just finally, I wanted to show you these data which show that actually dietary intervention reduces FGF23, but it reduces FGF23 even if plasma phosphate is normal. So without a change in plasma phosphate, suggesting that actually you're unloading these intracellular stores of phosphate when you phosphate restrict. So even if you have a plasma phosphate within the reference, within the target range, it's still worth phosphate restricting, with the proviso that you need to watch out for diet-induced hypercalcemia in those cats. And at the moment we don't really understand that phenomenon and whether it's harmful or not to the cats that have chronic kidney disease. We assume it is, but we don't really know for sure. And then just a very recent finding that we've reported is that magnesium should also be looked at in these patients, because if they're hypomagnesiemic, they tend to have worse bone mineral disturbances. Magnesium is a factor that influences vascular calcification. So about 20% of our cats with chronic kidney disease have magnesium levels that are below the reference interval for cats. And those cats with hypomagnesemia at each stage had higher FGF23 compared to the cats that had normal or had hypermagnesemia, which were relatively few cats that were hypermagnesemic in this study. So with 50 seconds to go, Bone mineral disturbances in chronic kidney disease are common, and it's an early finding. Phosphate overload results in reduced renal excretion, results from reduced renal excretion. The adaptation that occurs to increase renal excretion becomes maladaptive. There's strong evidence to support phosphate restriction provided by clinical diets to preserve kidney function, and I would say to suggest that starting that early in those cats that have evidence of bone mineral disturbance would be logical, but we don't have the evidence at the moment. The source of dietary phosphate and the ratio to calcium is likely to be extremely important, and FGF23 may be an indicator of phosphate overload, and we should look at magnesium, and we should treat hypomagnesemia, but we don't have any recommendations as to how to do that at the moment, but we're working on it. Thank you very much.